Hello everybody. Welcome back to my channel Preventive and Social Medicine. This is Dr. Mehtab, first year resident and Community Medicine Department. Today we will discuss about scabies, which is a neglected tropical disease. So definition is a contagious, intensely itchy skin condition caused by tiny burrowing mite called Sarcoptes scabies. Magnitude of problem. It's a neglected tropical disease included in it is included in neglected tropical disease in 2017, globally estimated to affect 200 million people at any time. Annual incidences of about 455 million cases. Prevalence ranges from 0.2 percentage to 71 percentage. So average prevalence is 5 to 10 percentage in children in poor socio-economic countries. Causative agent is it belongs to the phyla Arthropoda, class Arachnida, subclass Acari, family Sarcoptidae, genus Sarcoptes, species Sarcoptes scabies. So life cycle of Sarcoptes scabies. It undergoes 4 stages in its life cycle: egg, larva, nymph, and adult. Female deposits 2 to 3 eggs per day as they burrow under the skin. Eggs are oval, 0.1 to 0.15 millimeter in length. These hex hatch in 3 to 4 days to release larvae. These larvae migrate to the skin surface and burrow into the intact stratum corneum. They construct short burrows called molting pouches. Female mite is 0.3 to 0.45 millimeter long and 0.25 millimeter to 0.35 millimeter wide. Male mite is smaller in size compared to the female mite. It is generally slightly more than half the size of the female mite. So mating takes place in the molting pouches after the male penetrates into the molting pouch of the adult female. Mating takes place only once and leaves the female fertile for rest of her life. So these impregnated females extend their molting pouches into burrows and lays eggs. So these adult females deposit eggs as they burrow. So the serpiginous tract is formed. So transmission is by person to person or by fomites. Mites are found predominantly between fingers and on the wrist. So the areas are highlighted here in red color. The areas highlighted in pink represent the most common size where rash may occur, although they can occur anywhere else. So modes of transmission: prolonged skin to skin contact with an infested individual. So it is also seen in the sexual partners of the infested individual. In cluster scabies, contact with infested person, personal items like clothes, lining, bedding, anything. So it will result in transmission of scabies. So environmental factors: contact with infested person like household members, sexual partners, they are at a high risk of getting infected. So the persons living in nursing homes, extended care facilities, prisons, and child care facilities are at highest risk of transmission. So vulnerable groups are young children, elderly, disabled or debilitated persons, immunocompromised individuals, and communities where overcrowding and poverty coexist. So they have limited access to the treatment. So these scabies are of different types. First, the classical scabies. The common symptoms include intense itching and skin rash. Usually appears 2 to 6 weeks after infection. If the person is previously infected, he will show symptoms soon after exposure. So both immediate and delayed type of allergic reactions are seen in scabies. These allergic reactions occur due to the proteins and feces of the parasite in the skin. Normally, in classical scabies, 10 to 15 mites might be present in the person. So these are the common sites where the scabies rash will be present, called finger webs, wrist, elbow, armpit, penis, nipple, waist, buttocks, shoulder blades. It is represented by the circle of Hebra. It is an imaginary circle intersecting the main sites of involvement like axilla, elbow flexures, wrists and hands, and crotch. Has long been called the circle of Hebra. So one more is the scabies incognito. It occurs due to inappropriate use of topical steroids. It mimics other dermatosis. Corticosteroid usage reduce itching in these conditions, but inflammatory lesions and the mite population increases in these persons. So the infestation and transmissibility persists. They can infect other persons. So infantile scabies is seen in infants and young children. Here they present with the papules or vesiculopustules. They're commonly seen in areas like head, neck, face, palms, and soles. Next is the Norwegian scabies. This Norwegian scabies is the severe form of scabies characterized by vesicles and thick crust caused by superinfestation of the mite. Diffuse proliferation of mites are seen, characterized by hyperkeratosis and crusting of the skin. So early recognition and treatment is needed to avoid any outbreak. It is commonly seen in elderly, immunocompromised individual or those with altered host response. Like allergic reaction will be, itching will be absent in Norwegian scabies. In conditions like spinal cord injury, paralysis, loss of sensation, mental debility. So enormous proliferation of mites will be seen in Norwegian scabies. So normally in classical scabies only 10 to 15 mites were present. But in Norwegian scabies, thousand to millions of mites will be seen in the skin. Then nodular scabies. It is most common in children. Reddish brown pruritic nodules measuring 5 to 8 millimeter in size will be seen in groin, genitalia, axillary region. So these represent hypersensitivity reaction to retained mite parts or antigens. Pruritic persistent nodules for months, even after specific treatment for scabies will be seen. So we have to give additional treatment to them like topical corticosteroids and tacrolimus and intralesional steroids are to be given. Then bulla scabies. It is an intensely pruritic bullae seen on the extremities. Usually it is seen in the school-going age group. These bullous lesions may contain eosinophils resembling bullous pemphigoid. So these are the types of the scabies. Now we will discuss about the complications. Normally these complications occur because of the secondary bacterial infections like impetigo, deep-seated abscesses, septicemia, post-streptococcal glomerulonephritis, rheumatic heart disease. And acute renal damage is seen in children, in some of the children, like which persists. If it persists, it leads to the permanent kidney damage in 10% of the affected children. So let us discuss the differential diagnosis. So it mimics other conditions like, so first we have to rule out all these conditions like atopic dermatitis, pyoderma, dyshydrotic eczema, contact dermatitis, dermatitis herpetiformis, insect bite reaction, psoriasis, bullous pemphigoid, and any other drug eruptions. So how to diagnose scabies? History and physical examination, it is the most important method to identify scabies. It will be 100% sensitive and 97% specific. Then microscopic examination using electron microscopy, burrowing test, slide mount preparations, and handheld dermoscopy and skin biopsy. So first is the history and physical examination. 4 cardinal features will be present in the patient of scabies, like presence of burrows in the skin, characteristic distribution of pattern of lesion, like the lesion will be present in the circle of Hebra, and history of similar illness in the contacts, intense pruritus which worsens at night. Then microscopic examination. Slides are prepared using 10% KOS. It confirms the diagnosis when X mites, X casings or feces are seen in the slides. Then histopathological diagnosis of scabies done by skin biopsy, or it can be done using the skin scrapings also. It is reserved for difficult or atypical cases. It has it is highly specific, but it has less sensitivity because the mite may miss from the tissue which we have taken for the biopsy. The skin tissue is stored in 10% formalin or saline. Then the paraffin blocks are prepared and they are cut into 3 to 5 micrometer sections. These sections are stained with HND like hematoxylin and eosin for identification. These images show Skybala is the feces of the parasite. The necks are seen, then mites are seen. Next is the burrowing test. Here we infested area is touched with India ink or gentian violet. Then the ink is removed with alcohol, but the thin thread-like burrows will retain the ink. Then slide mount preparations. First, mineral oil is applied to the infested area. Then skin is scraped using sterile blades. These slides are prepared using KOH, potassium hydroxide, then examined under low power microscope. Then handheld dermoscopy. It is also called a scabioscopy. Scabioscopy. So epiluminescent stereo microscope. The instrument is held perpendicular to the skin. It reveals the scabies mites within minutes. It is a valuable tool for diagnosing scabies in endemic area. Next is that is a newer technique called superficial cyanoacrylate biopsy, SCAB. Here the small drop of cyanoacrylate glue is applied to a glass slide. It is immediately pressed to the skin lesion. After 30 seconds, slide is detached by a swift move. So the procedure is repeated at the other suspected site in a similar manner, then examined under conventional microscope. For clearer view of mites, the slides can be pre-incubated with 10% potassium hydroxide for 10 minutes. Next is the treatment general guidelines. What we have to follow. All the household members of the infested person and the sexual contacts of the infested person treated at the same time to prevent reinfestation. So bedding, clothing and towels used by the infected person and their contacts should be decontaminated before the treatment by hot water or hot dryer or by dry cleaning. If dry cleaning is not possible, then it can be sealed. Those bedding clothing can be sealed in a plastic bag for 72 hours. Mite can survive only up to 2 to 3 days away from the human skin. So after 3 days, it will not survive. So treatment. Application of scabicide over entire body below head. So cream should be reapplied to hands after routine hand washing. Itching may continue for several weeks despite successful treatment. In 5% of the cases, second time treatment may be necessary after 7 to 10 days. So treatment overview, we can use 5% permethrin cream. It is the most common treatment for the scabies. Then 25% benzyl benzoate lotion, 10% is sulfur ointment, 10% crotamidone lotion, 1% lindane lotion, malathion, and ivermectin. So we have to give symptomatic treatment also to the patient to control the itch. We have to give antihistamine, pramoxine lotion. To control any secondary infections, antibiotics ought to be given. To ease the redness, swelling, and steroid creams should be prescribed. So let us discuss one by one. So permethrin, also called as elimide, is a 5% dermal cream is effective. Applied to the whole body and left for 8 to 12 hours before washing. So second application is done after interval of a week. So after 7 days, we have to reapply. It can cause itching and reddening of the skin. So 30 to 60 grams of cream is needed for an adult for single application. Next is the sulfur. So 10% sulfur in yellow soft paraffin is safe and effective. Infants and young children, 2.5% topical sulfur is used. So excessive concentration may cause irritation. Then lindane 1%. It is a gamma benzene, also called as gamma benzene hexachloride. It is an organochloride. So single application for 12 to 24 hours before washing. 6-hour application is equally effective. Adverse effects and contraindications of lindane. It will cause seizures. So it should be given contraindicated in premature infants, pregnant or breastfeeding women, infants, children and elderly, and persons with seizure disorder or irritated skin or sores are present at the site of the application. So these are the conditions where lindane application is contraindicated. Next, malathion. So it is used as 0.5% in aqueous base. 100 ml of lotion is used for single application. It is applied for 24 hours. Then second application is done after a week. It is an organophosphate. It may cause skin irritation. So benzyl benzoate lotion, 25% emulsion is used. In children's, 12.5% concentration is used. It is applied for 24 hours before washing. For severe cases, treatment is repeated on the 4th day. It acts on the nervous system of the parasite. Then crotometon lotion. So 10% crotometon lotion is given, applied at twice, 24 hours apart. Then it is washed 48 hours after the last application. So the infected person and the contacts should use the fresh linen for all the 3 days. Then they should be disinfected after 3rd day also. Ivermectin. It is an oral antiparasitic agent considered for patients with crusted scabies or those with failed treatment or the persons who are intolerant to topical medication. Dosage is 200 micrograms per kg taken on empty stomach with water. So 2 or more days, doses 7 days apart are necessary to be effective. Next is prevention and control. What can we do to prevent scabies in our community? So first we have to avoid direct skin to skin contact with an infected person. Avoid contact with fomites used by the infected person like clothing, bedding, linen. So all household members of the infected person should be treated at the same time to prevent the reinfestation. Bedding and clothing worn should be machine washed and dried using hot water or dry clean or stored in a closed plastic bag for several days to a week. So the mite can survive away from the human contact only up to 2 to 3 days. So after that, the mite will be killed automatically. Then the close contact of the persons with the crusted scabies should be treated rapidly and aggressively to avoid outbreaks. Institutional outbreaks should be managed rapidly and aggressively. The rooms used by the patients with crusted scabies should be thoroughly cleaned and vacuumed after use. Environmental disinfestation using pesticide sprays or fogs is unnecessary and is discouraged. So this is all about scabies. Thank you.